I'm glad someone knows what they're doing.
I tell you, my head isn't that clear today, so you guys are going to have to watch me carefully. Um, all right. So let me tell you who I see, who we have written down, and then we'll go from there. Um, so I see Len um, and Jake, J. Bob, Jay Krugman, John Appler, Peter Kafka, Brian, Dennis Correa, Jeff Ledoux, Sylvester, Ken Anderson, um, Spokane Gary, and who is there anybody I haven't called out?
Jim Harrington, Rick.
Oh, Jim Harrington. I'm sorry, I did put it down. Jim Harrington. Anyone else?
Yeah, Bill Franklin's here.
Bill Franklin. Happy New Year.
Happy New Year,
Robert
guys.
Ellis. Oops. Robert
Sorry.
Ellis.
Morgan.
Robert.
Was that?
Robert
Robert
Ellis.
Sorry, Robert. Yeah, beg your pardon.
That's it.
Got you. Robert Ellis. Anyone else?
Jay Curran, but I guess you're calling me Jay.
Yeah, Jay Curran, I got you.
Oh,
Okay.
no, I did. That's the one I had wrong. Say it again. Speak up again, Jay.
Jay Curran.
Yeah.
Yeah.
That's the
Thank you.
unknown is Jay.
Yeah.
Okay.
Thank you for that.
All right. So you okay. So looks like we have and someone else just joined us by phone. Who was that?
That was Clay Morgan in Washington.
Clay Morgan. Okay, welcome, Clay. So it looks like we have two new folks today. At least I don't recognize the names. This is Rick Davis. I moderate this call along with Len Sierra and Jake Hannum. So Clay, I don't think we've spoken to you before. And Brian, is this the first time you've been on the call?
Yes.
Okay, well, welcome to both of you. I'm curious with each of you. Brian, how did you find us?
Through the Inspire site.
Okay, and how about you, Clay?
Same thing.
Okay, excellent. So what we usually do is give you guys some time up front if you're game, just to ask you to tell us a little bit about your age, your background, where you are in your disease path, and what concerns you have. And we'll spend about 15 minutes or so, 20 minutes with each of you. I mean, that varies. It can be more, it can be less, but we'll go through what's going on. And then when I've done all of that, I will do the roll call and see who needs some time tonight, because I know there's a couple of people that would like to speak. So so let's kick off with, we'll do it in alphabetical order. We'll go with Brian before we go with Clay Morgan. Is that okay by you, Brian?
That's okay.
Okay. So tell us, just tell us a little bit about yourself.
Okay, so I'm 56 years old. I live in Bartlett, Illinois, which is a suburb of Chicago.
Okay.
And a little over a year ago, I had a PSA test, and it was considered unnormal at a level of 4. And went to see a urologist for the first time and found out, you know, they were trying to determine what it was, if it was an infection or what have you. Took a while anyway, and my PSA rose to 16 by December, which was like 3 or 4 months. And so then I had a biopsy in February of 2017, which came back with a Gleason 9 score, and pretty much advanced prostate cancer throughout the prostate. You know, a lot of the samples were 100%. I then proceeded to have a CT scan and a bone scan, which both came back, you know, positive for metastatic disease into the skeleton, into the pelvic area, into the lymph nodes. And at that time, my PSA was 21. And then I started researching, you know, using the Inspire site a lot, actually, to find information. And my urologist at the time was recommending that I go on Casodex, and didn't really have anything else he was suggesting at the time. It concerned me a little bit because from what I was reading, it seemed that my cancer was fairly aggressive, moving fast. So I proceeded to actually call the Mayo Clinic, and just to see what their thoughts were. A family member had gone there and had very good results for another cancer. So they actually called me back the next day, took my story, and were willing to actually have me come there and see Dr. Kwan. And that was in April. At that point, the PSA had gone up to 25. They did the C11 choline scan and an MRI, and you know, he showed me probably more than 20 or 30 mets in my skeleton, and immediately recommended that I go on hormone therapy as well as chemotherapy through someone here in DeKalb, Illinois, which is just outside of Chicago as well, who they work with as far as the medical oncologist. So I did that. Did Taxotere for 6 cycles. PSA dropped considerably over that time. Went back for another scan midway, and it was looking good. Finished up in September with the chemotherapy, and most of the cancer, thankfully, had disappeared from the skeleton, or at least appeared that way through the scans, and my PSA was down to 0.2 at that point. There was still some cancer left in the pelvic and prostate area, obviously, and so we decided to go ahead and do some radiation as well. So I went for 20 cycles of IMRT radiation and completed that in December. My PSA is holding at 0.2. And I go back in February of 2018, end of February 2018, for a follow-up to see how everything's doing. So I've been fortunate, you know, at least so far, that things have been progressing well downward for me, and the therapy worked well, it appears.
Certainly some good results, and encouraging for a couple of guys on the call who have been diagnosed with metastasized disease recently and are just starting out on this path. When they did the IMRT, was this focused on the prostate, or was it on the pelvic girdle?
It was focused on both, because I still had disease in the prostate, as well as in the pelvic area, and some of the bone, and in some of the lymph nodes. So they designed it around focusing on that area.
So we'll open it up for because I'm sure there are a couple of guys that would like to talk to you because they're in a very similar situation that they're facing right now. But what specific questions do you have for us? And by the way, congratulations. I mean, to to have done that, to have gotten the PSA back down to around the 0.2 level is terrific, and bodes really well for you being able to manage this disease for a long time. But what do you have to ask us, Brian?
Well, I guess, you know, I've heard a lot about, you know, especially in the case of, I guess, the aggressive disease I had, apparently that it comes back and, or could come back. I guess that concerns me. They've talked about, they've given me kind of a break for now. And they've talked about potentially going on to Zytiga after February, depending on where things are at. So I guess that sounds like the next best thing to do at this point, as long as I guess it's staying down or it's not progressing. So I'm kind of curious as to what other people may have experienced or what people's thoughts on that are.
Okay. And when you say they're giving you a break, are you still on the androgen deprivation therapy, Lupron or Firmagon or whatever you're getting?
Yes, I'm still on Lupron.
Okay. And how are you handling the Lupron?
You know, I think I'm doing okay. I've heard a lot about that. You know, a lot of people have struggled with it, but in some others it doesn't affect as much. I think I've had fatigue, and you know, I think some of that just comes from knocking the testosterone down so far. You know, there's other side effects I've had too, but I would say I'm doing okay with it, and I'm hoping that, you know, I've also read recently that, you know, they're recommending now maybe only 18 months on that, but we haven't talked about that because I'm only, you know, I'm not even a year in yet, so.
They're recommending only 18 months on androgen deprivation therapy, you're saying?
Well, that's what I've read recently.
Well,
but
that's the case if you don't have metastatic disease, I think.
Okay, all right.
I think if you have metastatic disease, you're pretty much going to have to live with androgen deprivation therapy for the rest of your life, although you may have opportunities to come off it, and if you're interested in exploring that, there are a couple of guys right now on this call who are on ADT holidays, but the general thinking is that if diagnosed metastatic, it's kind of hard to get off, and it may not even be great to take holidays, but some people manage and do very well on it, and others do not. Ken Anderson, this sounds a little similar to your situation, no?
Yeah, I'd say pretty damn close. So,
you want to talk to Brian? Talk to Brian.
Well, definitely, Brian, you've had some pretty good results. My diagnosis was identical. I'm 56, or was 56 when I was diagnosed. So I live in the Southwest in Arizona, but you know, I had a Gleason 9, bone mets, lymph node involvement, did the chemo, did the radiation. The only difference is that I didn't go to, I went to MD Anderson versus Mayo, but it sounds like their protocols are pretty similar. So my PSA didn't go down to 2, it went to 6. Just curious if you know what your testosterone level is at the moment.
No, I don't. I think I'm trying to remember. I'd have to go back and look. I think the last time it was tested was back in September. But I know it was pretty low. I want to say 50s or something like that, but I'd have to look.
It's probably lower than that since you've been on it. When did you start Lupron?
I started in, well, first they gave me Firmagon for the first month in April, and then it switched to Lupron 3-month shots starting in May.
Gotcha. Well, you should, your testosterone level's probably today lower, but it'd be interesting to know what it is. And part of the reason for me being here today, Richard, is I have a question on testosterone level.
Okay.
So, but we can talk about that later. But I think you're doing great, Brian. Really, the mental side is hard to deal with, no doubt. And the fact that you're on like a little holiday, the holiday for me has been difficult. My radiation treatment has ended. I'm about 6 weeks, 5.5 weeks of radiation, and the doing nothing is almost as it's trouble.
Yeah, it sounds like we're pretty much exactly. I finished in mid-December with my radiation, and it's kind of nice not to have to go through anything for a while.
Brian,
How are you dealing with it mentally, and how do you... Go ahead, Richard.
No, you go ahead. Sorry.
No, I just was wondering how you're dealing with the sleep side, and are you sleeping well or having issues with sleep? How are you dealing with sleep?
I have had issues with sleep. In fact, during chemo and during even now to some degree, I have issues with sleep and have to take things for sleep. That has been one of the things that has. Are you having the same issues?
Of course. I think it comes with ADT. It comes with lots of stuff, but man, I don't know if it's just the Lupron causing it, or if it's that your mind's just busy because of cancer. So I don't know what it's from.
Okay.
Maybe Richard has more information on that than I.
Well, what I can tell you, I'm going to do a little advert right now, is that you should mark in your calendars the 29th of this month, the 29th of January, which is the 5th Monday of the month, where we are going to have a nationally recognized sleep expert talk to us about sleep and cancer. And his name is Ruben Nyman. I'll put it in the chat window. And we'll have a deck and what have you, and we'll have plenty of time to ask him. And I've asked Ruben to actually try and focus more specifically on the issues around cancer. I've heard him present as has Dennis. He's very good, but I want him to really try and explore some of the issues that arise through cancer. So let me. I'm just going to put it in here. Ruben Nyman. So for those of you who are on the phone, it's Rubin, and the last name is Neiman, and he works with Andy Weil at the Arizona Integrative Medicine Center. He's a longtime colleague of Andy Weil, so hopefully we'll be able to pass out some good information for you. I was going to ask you, Brian, your Gleason 9, do you know if that was a 5+4 or a 4+5?
It was mostly 4+5. I think I had some 4+4s.
Okay.
I don't recall but most of it I think it was 4+5.
Okay. No, thanks. I'm just making some notes here. So who else would like to talk to Brian about what other things one might do next, or other treatment options?
Hi, Brian. This is Dennis, and I think our diagnosis were very similar. Although I started out with my diagnosis at 70 years old, and now I've been went through a very similar treatment, starting with the taxane chemo, and the Firmagon, going to the Lupron, and was doing pretty good. But I had problems with the chemo, so they had to reduce my dose about halfway through. I ended up in the hospital with a low white blood cell count. And but as mine has started to come back again, fairly recently here, several months ago, I got some more scans, and I got a couple additional bone mets. And I have started on Zytiga with prednisone. And that has been, of all the treatments that I've had here, the best. I'm still on Lupron also. And have similar situations with problems. But I mean, for me, the main side effects, I knew it wasn't going to be any libido or sexual stuff anymore. That's done. But the hot flashes, I don't know how you're doing with those, if you're having those or not. Let's see. Oh, cognitive stuff, a little bit of cognitive issues. But the Zytiga has really done wonders. That brought me way back down to less than 1 on the PSA. And I actually, because I also have some arthritis issues, the low dose of the prednisone has done wonders for me. My arthritis hasn't felt this good since I initially started to have problems from it. But I think you took all of the right paths on the road from the start with your decisions that you made in the treatments and going to Mayo. I actually see a medical oncologist out of Mayo Clinic in Phoenix, even though I'm physically located in Tucson. But I use him as my main guy, and I do a local guy that he recommended here in Tucson for my routine blood work and Lupron injections and general monitoring. And then I'll continue to see him like every 6 months if things continue to go the way they've been going for me. But welcome to the call.
Well, thank you for sharing your information. How long ago were you diagnosed, Dennis?
A little over 2 years ago. I got it, let's see, in November, a routine PSA as part of my annual physical. And it had gone over, like you said, over the 4, which is the guideline that they have for, if it gets over that, most places that's what they use. And I think they should be using 3. But so I got that, and then I, got a second opinion. Again, I went up to Mayo Clinic and to get a second opinion from all of the other stuff that I'd gotten here locally. All my scans are reviewed and everything, and they came back same thing with the Gleason 9, 5+4, and very aggressive. Did the scans and had half a dozen bone mets and lymph node development. And so immediately, as soon as I was able, I did a lot of searching on where I was going to actually go for my treatments and what to do, but ended up with the doctor here that was in Tucson at the time, then has since moved to Mayo Clinic in Phoenix. So I've had to change to him. And the one thing regarding that respect, the doctor that I kind of inherited when my doctor left Tucson to go to Mayo, was a complete idiot from the standpoint of really looking at me and understanding me and what treatments were available. And if it hadn't been something that's been in use for 20 years, he didn't want to hear it. And I'm glad that I had, the fortitude to leave him behind and get out of there, because he wasn't doing me any good at all. And so the team at Mayo, the tumor board, after they reviewed the latest Oxman bone scan, they came back with the recommendation to start the Zytiga, which I have been on now for about 3, almost 4 months on the Zytiga, doing well on it. It's the best treatment I've had from the standpoint of how how well it's reduced my PSA. And you know, although I have, you know, the obvious side effects from it, I'm still able to be active, and I'm playing golf 18 holes twice a week and down here. And so the fatigue is there. Getting a good solid full night's sleep, you know, for 8 hours, that doesn't exist anymore, but I do get, you know, 4 hours generally solid sleep, and then it's kind of on and off for the rest of the night.
So, I have one suggestion for you, Brian, and I mean, you're doing well with Mayo, but if it were me, my concern with being treated by Quan is that Quan is not a medical oncologist. He is a surgeon actually by training, and he treats a lot of people who have advanced disease, but the reason he doesn't treat them at Mayo is because he's not the oncologist, and so he sends them out. And it's never really been clear to me why, other than for logistical reasons, like in your case, but why he doesn't treat at Mayo, but he does. And the suggestion that I'd like to make to you, if your insurance covers it, is there are two really good genitourinary medical oncologists in Chicago, and if it were me, I'd be wanting to add one of them to the team. I'm not saying to switch doctors, but I am saying that they may have ideas as you move forward in managing this disease, and it might be just good to get on their radar and see where they go, see where you go with that. One of them is at Northwestern, and her name is Alicia Morgans, Alicia, and the last name is Morgans, Morgans. Jake, maybe you can put that in the chat window, please. And the other guy's name is Walter Stadler, and he's at U of C. Both of them have really good bedside manner. We referred a bunch of people probably over the last couple of years. We probably referred half a dozen people between them, and everybody likes them very much. So I don't know whether you might want to, especially now that you're in a stable position, you might want to at least meet with them. But I think if it were me, I would want a recognized genitourinary medical oncologist on my team. Anybody else want to comment on that? Okay. How is your insurance?
It's good, and I appreciate the suggestions. The medical oncologist I'm working with now is in DeKalb, and his name is Dr. Siddiqui. He's the one who, got the referral from Mayo, and I guess he ends up treating a lot of Quan's patients from around the Midwest.
Right.
And I like him a lot. He actually was the one who was pushing me to continue my treatments and go into the radiation, where I was kind of like, I wasn't sure that I wanted to do it at this point, but he was the one who was kind of pushing me to get it while it's down, in the way he put it, as opposed to waiting any longer, for it to potentially grow some more. So I've been happy so far, but I do appreciate the suggestions. And as far as Dennis and the side effects from the Lupron, the cognitive issues, the memory issues, that bothered me a lot, because I was usually always on top of things, and it was hard. It was hard, especially initially, to deal with that. So I've come to deal with it and just accept it. But I do have to write things down more and all that. So yeah, that's one of the other things I did experience.
Well, what I would say is I have your email address from it was associated with your name here, so we'll put you on the distribution. Keep coming back. We meet every week. I'll put you when I add you to the distribution, you'll see the call notice coming through. You're very, very welcome to attend. There's a lot of knowledge on this call. You know, and some of these guys have been attending these calls now for many years. So hopefully you found it useful. And, you know, as you move through the journey, we can be a really good sounding board for you.
Great, I appreciate it. It's been already informative, and I'm glad I could share my story. And hopefully, you know, if anybody has any questions of me, you know, feel free. And
Absolutely. So if anybody does wish to get hold of Brian later, just let me know, and I'll put you guys in touch. Yeah, go ahead, Peter.
Yeah, I would just suggest to him to watch his PSA, and if it does start to climb, he could possibly talk to his doctor about Provenge, you know, early on, rather than waiting later on when he might not be in great shape. You know.
Right. That's a good point.
Provenge is an immunotherapy drug.
Right. Have you had any discussions about Provenge with your local doc?
no, I have not yet.
Okay. Well, one of the reasons why we strongly recommend a genitourinary medical oncologist is because most of the guys that practice out of community practices, they treat many different cancers, and the GU medoncs, who tend to be, not always, there are notable exceptions, but the GU medoncs tend to be at centers of excellence like Northwestern or U of C, and they are a lot more on top of some of the trials and some of the newer treatments that are available, particularly as they pertain to precision medicine and immunotherapy. Go ahead. Did you want to say something? Okay. So that's one of the reasons, but you know, we're only suggesting it as an additional and not an in place of, because there may be ideas they have, and we can also feed you ideas that you can take back to your doc and discuss with them. But as Peter says, the earlier you can get Provenge, the better you are. But you need to see your PSA rise, and thank goodness for you, your PSA isn't rising yet, which is great.
Okay.
Okay. So I'm going to welcome a couple more people to the call, and then we're going to talk to Clay. So there are a couple of people that have joined us on the telephone. Well, somebody just popped off when I said welcome. Ooh, never mind. Who is there? Anybody on the telephone that we haven't recognized yet? Okay. So let me just run down who I see on the call, and then if I haven't called your name, let me know. So we have Len, Jake, Curran, Jay Kruckman, John Atler, Peter, Kafka, Brian, Dennis, Jeff Ledoux, Sylvester, Ken Anderson, Gary, Jim Harrington, Bill Franklin, Robert Ellis, Clay Morgan, Larry Fish, Paul Frieder, Art Boosie. Is there anybody whose name I didn't call? Okay. All right. So Clay, why don't you sort of got the lie of the land there? Why don't you tell us a little bit about your situation?
All right. Well, I'm 54 and was actually diagnosed in 2010, so at the age of 47, and started a PSA of 13, and they did I forgot the name of it, the 12-core sampling, and I think 9 of 12 showed cancer at that time. And so we went back and forth, and I discussed doing a radical prostatectomy, which I decided to do in the spring of 2011. And so diagnosed with metastatic disease to lymph nodes, stage 4, Gleason 9 at that time. And so started ADP Firmagon in 2011. And then that my PSA remained a non-detect through 2011 after the surgery. So I'm with ADP. And late 2011, had another curve thrown at me, diagnosed with rectal cancer, stage 3A, and had surgery for that in 2012, and went through radiation therapy and full FOC chemo. And that has thankfully stayed at bay. So I'm officially on my beyond my 5th year of rectal cancer. But my prostate cancer, unfortunately, has been a little bit crazy, I guess, or maybe normal. But in 2013, my PSA began rising again, so I started Casodex, and that brought it down for, I guess, 2 years. Slowly started rising in 2016, and made the decision to go to Xtandi, only because I didn't want the prednisone from my previous chemo for the rectal cancer, but come to find out it's actually just replacement prednisone, so that was kind of a misunderstanding of mine. But anyway, Xtandi lasted through September of or October of 2017, and the PSA started rising again up to about 21 or 22, and I stopped Xtandi in November of 2017 to try to get into some clinical trials, and I was trying to get on a clinical trial for Lynparza, but did not qualify because the germline and also tissue tests did not show any mutations. So unfortunately I wasn't able to start that clinical trial. So currently I've had a CT scan in the last several months, and 3 lymph nodes are enlarged in the pelvis. I've never had any metastatic disease to the bones, so the bone scans are clean, and they've always been clean. And so I'm kind of wanting to know the next step, what people are recommending. My doctors, I'm working with a doctor in Washington, an oncologist, and then also I have family in Salt Lake City, and I have another doctor that's kind of a second opinion at the Huntsman Cancer Institute. And so I've been working with them for the past year or two. And I think both doctors are probably recommending to try Zytiga. I know it's a different mechanism, but I guess I just wanted to hear people's opinion whether Zytiga would be a good option or move on to Taxotere or I don't know if I'm really a candidate for Provenge. Maybe that's too far advanced for Provenge, but
You're not
currently
you're certainly not too far advanced for Provenge. Let me ask you, what was your original PSA when you were diagnosed at age 47?
13.
13. And you know, during the period between then and now, is 22 the highest that your PSA has ever reached?
Well, except for last week. You know, I stopped with Xtandi in November and have only been doing Lupron. And last week my PSA was 53.
Okay, so right now it's up to 53.
Yeah, so it's kind of doubling every 1 or 2 months.
Right. And when was the last time you did a scan?
Let's say 2 or 3 months ago.
Okay.
I think.
Still showing no involvement other than in the lymph system, yeah?
That's correct.
So, and the doctor that you have, well, let me backtrack with my question. Are either of the two doctors, either your local doctor in Washington, what part of Washington State are you?
I'm in the southern part near Portland, Oregon.
Okay, but
I actually could. I've actually gone to OHSU for some second opinions way back, 5-6 years ago, but I haven't been using OHSU.
Right. What's the name?
My insurance.
I'm trying to remember the name of the. What's the town there? The big town begins with a V, doesn't it?
Yeah, there's Vancouver, Washington.
Vancouver, Washington. That's it. Yeah. Yeah.
And that's where I am, just over the river from Portland,
right.
So very near Portland, Oregon.
Yeah, that's what I was trying to figure. Well, there are some really good genitourinary medical oncologists at OHSU. The one that immediately comes to mind is Thomas Beer, B-I-E-R. But I'm wondering if either of your docs are genitourinary medical oncologists, or if they're both general medical oncologists.
My one here in Washington is general, and then my one at Huntsman was specifically prostate. I've now been recommended to another doctor. I originally had a Dr. Cooney, and she is kind of the head of the medical oncology at the Huntsman Cancer Institute and University of Utah Medical Center. But now I'm moving on to Dr. Agrawal. And Dr. Agrawal is strictly prostate cancer.
And this is at Huntsman, Dr. Agrawal?
Say again?
Dr. Agrawal is at Huntsman?
Yes.
Oh, okay, because there is a GU medical oncologist at UCSF called Agrawal as well. That was okay. Who I know and who's a very good doc. So I think that the if it were me, I certainly would be opening up the Provenge discussion. You're probably right in the sweet spot for Provenge, and from the standpoint of where you might be able to get it, probably OHSU is probably going to be the most convenient, because you don't really want to be flying back and forth to Huntsman every 2 weeks whilst you get it. So you may be able to arrange to do that at OHSU. How long did you last on the enzalutamide? You started sometime in 2016, and it lasted through October of 17, right?
Yeah, approximately 10 months, 9 months, 10 months.
You could get something out of it. You could get something out of the Zytiga. Certainly possible. We've got to, I don't know if there's anybody on the call right now, but we've got a couple of guys that have disease that has developed, but still remains in the lymph system. I'm going to ask Len. I'm going to ask Len to speak to you in a minute. But one of the possible options that you might want to consider, since it's still in your lymph system, and which seems to be more and more prevalent, as you heard from the beginning of this call, is to radiate your whole pelvic girdle. Obviously, you don't have a prostate, so there's no cancer to take out the prostate. But Len, why don't you talk a little bit about your situation for Clay and see if there are any ideas that come out of that. We don't hear you, Len. Okay. Are you muted? No, you're not muted. All right, and it shows that we'll come back to Len. Is there anyone else on the call? Is Tom Van Zandt on the call? No. Okay. So is there anyone else that's on the call who has had more advanced disease and has done radiation? Ken Anderson, I know.
Hey, Rick. Rick, can you hear me now?
We can hear you, Len, yeah.
Oh, you can? Okay. Would you like me to talk to
Please,
Clay?
yes, please do.
Okay, so I guess first question would be, do you know which lymph nodes are involved?
There's one that is periaortal, and I think there's two that are near the kidney, well, in the vicinity of the kidneys. I can't say exactly.
Yeah, see, that may be considered to be beyond the reach of pelvic girdle, Rick. I'm not sure about that. Do you know any more about that?
No,
I think it is beyond the reach.
Don't.
Oh, okay. Which may be why they never recommended radiation to you. Or have you ever had that discussion with any of your doctors?
I did back in 2011, and it was kind of some recommended it, some didn't, and then I decided not to do it, and it ended up being better because if I would have had it, I wouldn't have been able to do the surgery on my rectal cancer.
Mm-hmm.
Right.
And then I did have radiation after my rectal surgery down in the pelvis area because that's where the in my rectum and around the prostate bed. So I had some radiation, or a full course of radiation then.
Okay.
But I haven't. There hasn't really been any other discussion about radiation currently. I mean, I can bring it up. I'll bring it up, but.
Yeah, it's worth bringing up, but I suspect they'll say you're not a candidate. Regarding other options, you may already know that there's only a very small percentage of guys who, once they fail enzalutamide, respond well to Zytiga. You may be one of them, hopefully.
Low percentage.
Very low percentage, yeah. Now, the other issue with Provenge, my recollection is that they like your PSA to be below 20, so they may not consider you a candidate for that either. I could be wrong about that, but that's my recollection. They don't like your PSA to be too high.
Yeah.
What type of scans have you had?
Len, let me just say, I think that's more related to tumor burden. And, you know, while the PSA is high, if there's no evidence of any other tumors anywhere else in the bone or the soft tissue, then, you know, now might be a really good time to do it. I think it's more related to tumor burden than it is to the actual level of the PSA, but I'm not sure. We're not doctors, we don't know, but it would certainly be, it'd be a discussion that I would want to have with my treating medical oncologist pretty quickly, Clay.
Okay. Yeah, I'll meet with both within the next 2 weeks, so.
Okay. Sorry, go ahead, Len.
Well, I mean, hopefully they'll consider you a candidate for Provenge, because with that you can get that finished and very rapidly move on to something else. I think it's only about something like 3 weeks for the entire course of Provenge treatment.
Uh-huh.
Yeah, so
6 weeks.
6 weeks, right? So I'm thinking Taxotere may be your best option, but yeah, definitely have all these discussions with your oncologist about Provenge and whole pelvic girdle radiation. But it does complicate things, I suppose, with the rectal cancer. Maybe contraindicated the full pelvic girdle radiation if you had rectal cancer.
Okay. But they call it
only further.
They call it full pelvic radiation therapy.
Girdle.
Yeah.
Girdle.
Yeah. Right.
What's your feeling about radiation, Clay? About chemotherapy? I'm sorry. Have you had discussions about chemo, and what's your own personal feeling on that?
I've not had a discussion on the Taxotere. I think both doctors are wanting to run everything else out before they start chemotherapy.
Mm.
But I'm not opposed to it. I went through it once. I don't particularly want to do it again, but I can.
Well, I mean, the reason I ask is because it appears to give the biggest bang for the buck. So I mean that's why you might want to discuss it with your docs when you have these upcoming meetings.
Okay.
The earlier you get it, the better it seems to be effective, and particularly if it's only in the lymph system. Although I'm not aware of any research where they've done any studies for men that only have lymphatic metastasis. They may be out there. I mean, that's the sort of thing somebody like Thomas Beer would know, or one of the guys at the University of Washington at Fred, forget the name of the hospital in Seattle. It's just gone from my mind.
Yeah, I know what you're talking about, though.
Is that Fred Hutch?
Hutch, thank you. Thanks, Len. Yeah, either Hutch or OHSU would know, or possibly at Huntsman. But I would, I think that the discussions should probably involve, if it were me, I'd be talking about radiation, pelvic girdle radiation, I'd be talking about Provenge, and I'd be talking about chemotherapy.
Okay.
The question is, would you try chemotherapy before or after you tried Zytiga? Tough to say.
Yeah, I was wondering doing Zytiga and then pursuing Provenge, but
I think if it were me, I think I'd be trying to get the Provenge under my belt as quickly as I could.
before it gets spread out further. Yeah.
Yeah, I mean, Len has a point that there is greater resistance because as the tumor burden increases, we know that the Provenge is less effective. But you've got something pretty strange going on there in the terms of no real evidence of spread according to your scans, but your PSA climbing. And some men just make a lot of PSA. That's why the actual level of PSA is not necessarily a restriction. I mean, you can have guys that have low levels of PSA and lots of METs, and now of course they could measure your circulating tumor count, your circulating tumor cells, your CTC, and if the circulating tumor cells are low, then you're going to be eligible for the Provenge. But that's a discussion to have with your treating doc. Anybody else like to address Clay's situation with him?
Rick, this is Jim Harrington. I would because I think you said something that's really important. And Clay, I would say that, first of all, I've had a prostatectomy. I've had radiation. I'm one of these guys that does not make a lot of PSA. But putting that aside for the moment, I've been on docetaxel for, 3 or 4 months. I've had like 12 to 16 infusions, and it's not fun. But in terms of bang for your buck, there's no way to, I think chemo is got it. In that sense, I've had the other drugs you're talking about. I'm on Lupron for life and so forth. But my cancer now is flat out being controlled by docetaxel. And as Rick knows, we've talked a lot about this. When my PSA goes up, right now it's between 3 and 4. It kind of bounces around, but it's steady. But it's probably going to increase. So probably switch me off docetaxel and put me on carboplatin. I think I would say is that when you see your doctors in the next couple of weeks, be sure to mention chemo. You say you're not really adverse to it. It's not fun. Fatigue is not fun. Sleep problems. The things we have right now, neuropathy for me, I've got some of that, but it does work. And the thing that, how many you have, how many chemo treatments you'd have. If you have 6, in my case, it's a little bit discouraging, but my doctors tell me that it's indefinite, which is not a lot of fun to hear that.
Yeah.
But on the other hand, I have bone mets all down my spine. And I've got some problems with the liver and the lungs, some parts in the scan. So we're still doing those. But I think I would just echo what Rick said, is that be sure to think about chemo. Actually, I do really well with docetaxel. No, I don't like the fatigue and so forth. But I must say there have been many on the call and many people I know who struggle a lot more with this drug than I do. And so it's something to talk to your doctors about for sure, because where your PSA is, you talk about a doubling time that's fairly rapid. I think I certainly would consider the chemo. And I've had radiation too. I've had all the Zytiga and so forth. So anyway, that's my recommendation, to be sure to look carefully at the chemo, I guess. And I think many can just handle 6 treatments or so. It just didn't happen to work for me. I just keep on it, and as long as I keep on it, everything stays pretty much the same. Good luck to you, Clay. Good luck. Wish you well.
Thank you, Jim. Appreciate that.
So, Clay, we've given you a few good ideas. I don't have your email address, but if you would like to send it to me, I'll give you our email address. It's info, info at ancan.org, ancan.org. And if you send it to me, we'll add you to the distribution. And so you'll know there's a call every week. You'll get an advance notice of the call. Keep coming back. Keep talking to us. There's so much knowledge on this call, as you can hear. And people have been through what you might be considering. If you decide to do Provenge, there are plenty of guys that have done it. They'll tell you what to expect. And we'll keep talking to you, and we'll help you any way we can and guide you, navigate you in the best direction.
All right. Much appreciated, everyone. Very helpful. Thank you.
Pleasure.
Rick, I have one quick question.
Yes.
And, this I don't want to take it off the course, but I was intrigued by your secondary cancer, your rectal cancer, and wonder if you've ever had genetic testing.
Yes, I have.
I was tested. I had genetic and found out that I have a 50% chance for colorectal cancer because of a gene defect, and I was just shooting in the dark because of my prostate cancer and seeing if I was passing anything on to my sons.
Yeah, actually, about 6 months ago, I did get a germline testing, and yeah, nothing stood out. So not a familial cancer, which my kids are happy about, but I'm not happy about.
Right. Yeah, you mentioned that you had germline, that there was no germline mutation, and you know it's hard to get onto olaparib or any PARP inhibitor unless there's and it's probably not going to be effective unless you have some sort of a mutation.
That's right. Yeah.
Now, you know, the only other consideration is whether you would want to do a sequencing of your lymph nodes. They biopsy your lymph nodes and they sequence that. But I mean, it's again something that's worth discussing. But right now, if we can bring your disease under control with some of the without the precision meds, then you know that's probably a better way to go. If we cannot, then you start talking about doing a lymphatic biopsy and getting that analyzed. Peter, what was your, was it MLH1 your mutation?
MSH6.
MSH6. Okay. MSH6. Okay. And Clay, yours pointed nothing out. Is that right?
Yep. Pointed nothing out, and they also recently sent in a tissue sample from my prostate, and that didn't show anything either. But I do agree with you that I should probably get something more current from a lymph node if possible, or wherever.
Well, the thing is that the tissue sample from the prostate is all the way back from 2011, correct?
That's correct.
Right, yeah. And the disease has probably changed significantly since that point in time. So that's not a real, I mean, I'm not sure that would have been that useful. But what you really need is something more recent if you want to do a somatic test.
Okay. Yeah, I'll talk at the Huntsman. I'll talk with them about that. That's kind of their focus is genetics.
Okay. All right. So let me just run through who I see still on the call, and then I will go down everybody and see who would like some time. So I see Len, Jake, Jay Curran, Jay Kruckman, John. Oh, I think John Appler's left. Peter Kafka. Brian, Dennis Correa, Jeff Ledoux, Sylvester, Ken Anderson, Gary, Jim Harrington, Bill Franklin. I think Robert Ellis may have left. Clay, Larry Fish, Paul Frieda, Art Boosie. Is there anyone else on the call whose name I did not call out? Okay. So let me run down. Starting Len, do you need any time?
Not for myself, but if we have any time, I can talk a little bit about my visit to Jim Cammon.
Oh, yeah. We try and make time for that. Jake, any time for you?
No, Rick.
Okay.
Thank you.
Jay Curran, do you need time?
Yes. Okay.
Jay Kruckman, do you need time?
Not tonight, thank you.
Okay. Is John Appler still with us? No, I don't.
Yes, I am, Rick.
Oh, you are?
No time, Rick.
Do you need?
Yeah, I'm okay, Rick. Thanks.
Okay, good. Peter Kafka, do you need any time?
Yeah, I could take a couple of minutes just to mention what I've discovered on my clinical trial search.
Okay. Dennis Correa, any time for you?
No, I don't need any tonight.
Okay. Jeff Ledoux, any time for you?
A minute or two, if that would be all right.
Okay. Sylvester, any time for you?
No, thank you very much.
Okay. Ken Anderson, any time for you?
Yeah, just one quick question.
Okay. Gary, any time for you?
No.
Okay. Jim Harrington, you wanted to talk about neuropathy a little bit, correct?
Yeah, just a little bit. Yes, if I can get any help. Yes.
Bill Franklin, any time for you?
No, I'm just listening in. Just tell Peter I sent him a private chat.
Okay. Okay. Peter, look out for the private chat. Robert Ellis, are you still with us? I thought I saw you left. No. Okay. And Larry Fish left. Paul Frieder, any time for you?
Nothing for me tonight. Thanks.
Okay. And Art Boosie, any time for you? Art, are you still with us? Oh, I
don't see his name on the list.
No, he was on and he was off. And so I guess he's not here. All right, guys. So we've got, let's see, 1, 2, 3. We've got 6 people. So we need to be relatively short. And I'm actually going to ask Len, because I think it's important from the standpoint of the call. I'm just going to ask Len to talk about Jim Cammon for 4 or 5 minutes, because Len and I have kind of learned about Jim's situation over the past few days, and then Len was a saint today and made a visit. So go ahead, Len. Talk about Jim.
Sure. Yeah. Many of you may know Jim's been on these calls for years. Jim Cammon, you may know him as Venice Jim. He's down here in Venice, Florida. He's had a rough time in the past few months. Rick, you actually may know more about the details of his morphing prostate cancer, but I'm only going to speak about my visit to him. He's currently in a skilled nursing facility in Sarasota, which is just north of Venice. And to be blunt, he asked his doctor, was there any hope? The doctor said no. He's not, there's no treatment that will work for him at this time. He's not expected to go home. He's going to be transferred from the skilled nursing facility in Sarasota closer to his home and closer to his wife in Venice. It'll be a hospice type situation there. I can say this, I spent about a half hour with Jim and Pam, his wife, and my wife, and he seemed to be in relatively good spirits. Of course, he looked weak and tired and pale, but we were talking about his baseball collection. He had to sell over 7,000 memorabilia. He was quite a collector of baseball, signed autographs and that sort of thing, yearbooks. I don't know what to say. He's a really nice guy, those of you who know him, and he understands that he probably only has about 3 months left, and he seems to have accepted that. And Well, I'm sure we all wish him well. He did ask me to convey his greetings to all of you folks, Rick and everyone else on the call. And I told him I was the emissary of good wishes for him as well, from all of us.
Thank you. So yeah, as you may recall, Jim was diagnosed when his cancer came back. He was diagnosed with a very rare strain called spindle cell cancer, and you know, it's just a very difficult cancer to treat, and it's spreading. And then he had some surgery. They had to remove a good portion of his colon, and my understanding is he can't walk, and so it's not possible for him to be at home because he's a big guy, and his wife cannot manage that. So I put his email address in the chat window, and for those who are on the telephone, I'll tell you what it is. It's Jim Venice, all one word, Jim Venice at Comcast.net. And if any of you feel like you'd like to send him a note, I'm sure he will be very pleased to receive it. And we'll keep you updated. And truly, Len, thank you so much for going to see him today.
Sure, my pleasure.
Yeah, thank you, Len.
Okay, Jay Curran, you needed a little some time. Please go ahead. Jay Curran?
Yes, go ahead. I'm up.
Go ahead.
Okay. Go ahead. Okay. I have finished a Provenge course of treatment, and I'm on Firmagon. Been on Firmagon for about, I guess, 6 months, and my PSA is doubling. So I have an appointment with Dr. Ryan on the 5th, and I imagine he's going to tell me he's Zytiga. But I'm still thinking about Lu-177, so I just thought I'd try to get some thoughts about that. Maybe Cornell has trials.
Well, I can tell you pretty safely that there are no open trials right now, and I know that because Dr. Steve was looking around for trials for himself, and he is going to start Lutetium-177 in Los Angeles on the 20th, but he's having to pay for it out of pocket. So we really don't know anywhere that it is available. They were willing to donate the substratum, which I'm not really sure what substratum is. Len, you know what substratum means? Is that the medium that holds the Lutetium-177?
I'm afraid I don't know, Rick.
So they were willing to donate the substrate. Steve said he might come on. I spoke to him earlier today. He said he might come on the call, but he's not. But I think the problem is, and the other thing is that if you are going to do Lutetium-177, they require that you do a Gallium scan beforehand. So then you've got to figure out where you do your Gallium scan. So I have to say, I'm not really sure where you're going to access this Lutetium-177 just yet. Have you done chemotherapy?
No.
Well, you know, again, I think they'd probably be wanting you to do chemo first, and that's where you're going to get the biggest, as we've said earlier on. That's where you're going to get the most value. So you really would want to look at chemo, and I wouldn't put that off. If it were me, I wouldn't be wanting to put it off too long because we know that it has a really significant impact.
Okay. Now, I guess they do Lu-177 down in Australia. I don't know what your opinion of that situation is.
Well, yes, it's available in Australia. We know guys that have gotten it in Australia. But my question to you is, how would you access it in Australia?
Well, I'd fly down there. I've talked to Dr. Lenzel, and I'd have to pay for it.
Well, that's right. You know, and it's a very, very expensive treatment.
Yep.
And you could also access it in Germany. But if you're willing to pay for it, then you might want to pay for it in Los Angeles. It's a little closer than Australia, like Steve is.
Okay.
But I honestly don't know the terms of the trial that Steve is participating in. You know.
Well, go ahead.
No, you go ahead, please.
Well, what I found out was, and this was a couple of months ago, or maybe a month ago, they were working with a group in Houston, and they were sharing the same
Correct.
numbers of people to do their study.
Right. Right, that's correct.
Okay.
You can access it in Houston, or you can access it in Los Angeles. Steve originally was going to go to Houston, then he decided that LA was a lot closer, as it would be for you.
Okay.
But are you aware? So, are you aware of the trial in Los Angeles?
I am, but I don't think I've actually talked to them.
Okay, so
it's UCLA, right?
No, it's not at UCLA. It's somebody outside of UCLA.
Oh, okay.
Just as it is in Houston, it's with a private practitioner in Houston too.
And the gallium test, are you saying it's a little hard to get that, or you have to get a referral from a doctor, or
it's hard
something like that?
No, it's hard to get it. It's hard to access it. It's difficult to access.
Okay. Okay.
Have you? I can't remember. Have you had? Do you still have a prostate, Bob?
Yeah, I still have a prostate.
Okay. So if you did not have a prostate, you could probably, or if you'd had radiation, you probably could access it at through Stanford. But I mean, you know, there are, but the gallium, that there is a gallium trial going on there, but you have to have had either a radical prostatectomy or a or stereotactic radiation to the prostate. I'm not sure. Maybe IMRT. I don't know enough. But you wouldn't be eligible for that trial. Now, you know, that's another discussion to have with. I mean, there are other options before going to the lutetium. I don't know. You know, I guess if it were me, I probably wouldn't be jumping quite to the lutetium just yet. You can certainly talk about debulking and some radiation to your prostate and maybe to your pelvic girdle. If you're willing, you know, if you're interested in radiation, maybe, you know, start with some radiation to your prostate and to your pelvic girdle. That might be a good discussion to have with Chuck.
Okay.
You know, we have to watch out. I mean, I know that some of these new treatments sound sexy and great, but there's no magic bullet. And, you know, when for somebody like Steve Bornstein, who has done chemo, who's done radiation to his prostate, who's done radiation to his pelvic girdle, who's done enzalutamide, who's done Zytiga, and all of these different treatments, he doesn't know where to turn. But that's not your situation. You know, you have second-line anti-androgens, you have chemotherapy, you have possibilities with other types of radiation. So, you know, those would probably precede, most treating doctors would suggest that you try some of these things before looking to something like Lutetium-177.
And the reason for that is that Lutetium-177's untried and it doesn't have a large N and doesn't have clinical trials to back it up.
Well, it's not available. I don't think it's been. I'm not aware of trials where it's been used earlier in the disease process, but that doesn't mean to say it couldn't be very effective. So you'd be taking a gamble. It's very expensive. I mean, Steve is going to be paying about $7,000 per treatment.
Yeah.
And
they do 4 treatments.
Right. So, you know,
they do 4 treatments. Go ahead.
Yeah. So, I mean, if you wanted to take a financial gamble on that before looking at some of the options, other options, let me throw it open. Anybody else want to talk to Jay about Lutetium-177?
I think I would agree with you, Rick, that it seems a little early to be considering lutetium. It is experimental, and Xofigo is already approved, and yet even Xofigo is normally used at one of the very late stages of progressive prostate cancer. Yeah, I'm sorry, I was typing in the chat window when you first started talking. I may have missed. Do you have bone mets?
Yeah.
Okay. Yeah, I would agree with Rick. The second line anti-androgens will probably be a better first step unless you have a horrible time with ADT.
I weep, I cry, I have excessive fear, and that's all from low testosterone from Permagon.
Okay. Okay.
Yeah, but you see, even if you did the lutetium, you're not going to get off of the ADT club.
Okay.
I mean, it's the ADT is there for life. I mean, the one thing we do know that seems to have the greatest effect the earlier you use it is the chemotherapy. And even though there are a lot of men that are, you know, ABCs, anything but chemo. And it's not fun, but it works. And it certainly isn't going to cost 28 grand. And that's probably going to knock the cancer back more than anything else that we know right now for somebody with the sort of disease that you have.
Okay.
Rick,
and go ahead.
Rick, I wonder if it's worth having him contact Jim Marshall just to ask, you know, what are the guys over there going through lutetium over in Australia? Get some first-hand reports.
I had a chance to talk to Jim at the PCRI.
Okay.
Okay. Well.
Okay. Okay.
Yeah, I mean, you know, let us know what Chuck Ryan says, and but I think you'll probably find that they're going to be pushing some of these earlier treatments.
One thing that he said that encouraged me was that the prednisone dose is about the same as what our body produces anyway. So maybe the side effects might take them a while to kick in.
Are you talking about if you took Zytiga? Or
Yeah.
you went with chemotherapy?
Zytiga.
Well, I mean, I'm not sure that. So one of your concerns is the prednisone if you were to take Zytiga?
Yep.
Then why not take enzalutamide?
Is that Xtandi or no?
Xtandi, yeah.
I don't know if I want to take it because it works through the pituitary, and Zytiga is more. It's a different mechanism. I don't think it involves the pituitary.
Well,
it's a testosterone synthetase inhibitor, so it's going to drive your testosterone down below 5. So if you're worried about low testosterone and the side effects of that, Zytiga is going to give you more problems. You know, the prednisone is the least of your or anyone's problems when it comes to taking Zytiga.
I mean,
yeah, my testosterone's down. Go ahead.
No, as you've heard, as you heard Dennis Correa say, life has been great for him since he started taking the prednisone.
Yeah. My testosterone's about 7.
The prednisone I take is about 0.5 milligrams twice a day with a meal. I take it at breakfast and I take it at lunchtime. And
I think you mean 5 milligrams, don't you?
No.
0.5 milligrams?
Let me check. What's my Zytiga dose? 0.5?
No, you said prednisone.
No, I'm sorry, did I say Zytiga? Prednisone. In my prednisone, it's 2.5 milligrams. Sorry, 2.5 milligrams.
Right.
Twice a day.
Okay.
But it's to replace some of the androgens that are being stopped by the Zytiga. You know, the Zytiga stops all of the androgens, that includes the testosterone from the testes and the tumors themselves and things like the adrenal glands. So it gets all 3 sources that are producing testosterone. But in the case of doing that, it does take away some of the androgens that the other organs in your body need to keep functioning. So that is what the prednisone is for.
Okay.
Okay, we need to move on because
thank you for your help.
Half an hour left.
Yeah.
So you know, just let us know. But you know, the lutetium 177 is not a magic bullet. It's not going to put you in a place where your testosterone, you'll be able to get your testosterone back, and you won't have to take steroids. You know, it's a good alternative, but I think that there are probably some other alternatives that you might want to consider first.
Okay, thank you.
Okay. So Peter, you wanted to talk a little bit about the trials that you are looking at.
Is that me?
That's you.
Okay, this is just a quick one. You know, I wanted to get a Gallium-68 PET scan. So I started looking through trials, and there are several around, but they're all a little bit different. You really need to read the fine print and do your research. So I found a scan that I'm eligible for at UCSF, and then Rick mentioned there's another one at Stanford, but they are different. And there's another one at UCLA, but that in turn is different. The ones in Stanford and UCLA require follow-up every 3 to 6 months for a while, and not living on the mainland. It would require me flying back and forth and so forth. And then I read something And I was reading something that Adele wrote. What's the name? Alan Adele?
Mm-hmm.
Where he talks about the difference between scans that have a CT component and scans that have a MRI component. And he says in here that I'll read it just quick. I can find it. Anyway, he says the scans that have the MRI component are far more accurate than the scans with the CT component, but the only places with machines are places like Mass General, Hopkins, UCSF, Washington, and so forth. So the trial I want to go to has the MRI component, which has a much lower dose of radiation than the PET-CT. And it says PET MRI is able to detect 42% more metastasis in recurrent patients, 10% more lymph node metastasis, and 21% more bone metastasis than the CT PET. To me, that was a selling point, and it's so I'm going ahead with that. The person I contacted responded to me right away the next morning and told me I was eligible. I sent the paperwork over to my doc, and today they even on the holiday they said they were working on the paperwork and sending in the request. So that's my choice, is to go with UCSF, because that's what's that?
We're a little confused. Where is it that you've selected? Which trial have you selected, and what does it feature?
UCSF, because it has a PET MRI machine, not just a PET CT machine.
I see.
It gives me that option.
Okay. Okay. And is it going to cost you?
It'll cost me $900 because Medicare doesn't cover the actual infusion. So that's out of my pocket, $900.
Okay.
Plus my airfare, of course.
Of course. And who's running that trial? Is it Tom Hope?
It is. The woman in charge of it is named Dora Tao.
The doctor, or is that the trial coordinator?
Yeah, Tom Hope is the investigator.
Okay. Okay. I think that he's been doing this trial. He's been running this trial for a couple of years now. So it's good that you're eligible for it. I think you have to have had your prostate removed, if I'm not mistaken, to be eligible.
Either one, prostate removed or radiation.
Or radiation, right.
Either one. I think he's done several of them. I think there was one or two that closed recently, and this one's open now.
Okay, yeah, it could be this whole series. And when do you plan to do it, Peter?
I don't know. As soon as they get the paperwork from my doctor, I can call up. Probably the end of February is my guess, if they can take me in.
Well, this research makes you now the go-to guy for Gallium-68 trials. So anyone who in the next few weeks or months wants to know where to get their Gallium-68 trials, we know who to ask.
Right, just read the stuff carefully, because they're all a little bit different.
Okay, good job. Very good job. Maybe we can, Len, garnish those we can garner those trials and stick them into your program.
Yeah, that's an interesting one.
Yeah.
Would be a good idea.
Yeah. We'll talk with Peter, and maybe Peter can send you his notes, and we can write it up and get it into the clinical trials program that we're running.
Okay,
Because he's done the work. Thanks, Peter.
That's right.
Thank you, Peter.
Okay.
So Peter, you're in and out one day?
Sounds like it, yes.
Okay, good.
Peter's also the guy to talk about jumping over volcanoes and lava pits and. I don't know, have you looked in the
Where did
chat
that
window?
come from?
Yeah, I have. I have. But we've got to keep. I'm sorry, but we've got to keep moving along because we've still got 3 or 4 guys to get to here. Jeff Ledoux, you're up. Jeff Ledoux, you still with us, Jeff? All right, we'll come back. It shows that he's still with us, but he may have walked away from the phone or something. Ken, why don't you go, and then we'll come back to Jeff.
All right, I will. The question had to do with testosterone level. 60 days ago I had my blood work done, and my testosterone level was like 14 and it was 7 and 0.9, and then just recently I had it done again, and it had gone up to like 14 and 1.9. So I was wondering if you guys, and I was reading something that the ideal or what someone should shoot for as far as testosterone level, if you can possibly shoot for something, would be something like equal to or less than 7.7. Does any of that ring true, or is I'm just talking craziness? Because it had me mental for a little while, thinking that my testosterone level was running a little too high, because the thing that I'd read stated that the overall survival timeline was half if you were higher than 7. Does any of this ring true, Rick?
Not that I mean, what I'm familiar with is that they want to get it below 20, but that's probably out of date at this point in time. I mean, years ago it was below 50 when I did my treatment, and then they said, oh, we now want to get it below 20. And I haven't seen the studies that you're talking about, although they may well be correct. Is anyone else aware of target levels for testosterone on the call?
Rick, I don't know if it's testosterone levels, but I got mine back today. It was at 2.5, and the notice at the bottom of the report was if it's less than 12, it's useless because it really doesn't exist. It's a machine error, I guess. So, you get down into that level, you're in the weeds.
Yeah, I always heard less than 20 is castrate, so that's what they're looking for. Anything under 20 doesn't make any difference where it is down there.
And
I agree.
Ken, you're throwing out 2 numbers. What one number is testosterone? What's the other number? Is it dihydrotestosterone?
On this report, it says free testosterone 1.9 L, and it says testosterone total CMSMS 14 L. And those numbers were my most recent.
Right.
From Sonoran Quest Labs, and it's just that they've doubled since the last lab work was done. It's gone up twice as much. And I know the girl, or the lady that's my oncologist, medical oncologist here in Phoenix, she said, don't worry, we're going to look at it real close next time it comes in and see if it's a trend or if it's just some fluke.
Right.
So, and I started reading, like the ideal testosterone level, and I think they were saying the ideal for someone like me, the ideal testosterone level at kind of this point in the game for me should be equal to or less than 0.7, which,
is that
30 days ago.
Well, is that free testosterone or is that the overall testosterone?
Free testosterone.
Free testosterone.
Free.
Right. So I don't, to be honest, I don't understand the difference between free testosterone and testosterone.
I'm going to ask Corn in my email too. I'm going to ask him what the difference is. He's probably going to say I'm crazy, but I'm still going to ask.
Right. I don't know. Somebody, Len, do you know the difference between free testosterone and testosterone?
Yeah, no, unfortunately, I don't. I think it might be of importance to someone who doesn't have prostate cancer and maybe has impotence or something, and the free testosterone might be a more active form. But for us, I don't think it matters. I agree with you and everyone else who said if it's less than 20, they're usually not too anxious or worried about it.
Right. I mean,
the point, I wonder if it's a matter of units. It's normally measured as nanograms per milliliter. So if you're talking about 0.7, that might be not a nanogram, but a microgram. And I don't know. It could be a question of units.
Let me interject here. I mean, I think that there are two different measures that he's looking at: the free testosterone and the the regular testosterone. So the free testosterone, I don't know what units it's measured in, but the fact that it's 0.7 sounds pretty realistic. I mean, I've heard numbers like that. I would be interested to see whatever you read that said that the target should be less than 7 for people that are in your situation, Ken.
I'll send it because I have. It was a clinical trial, and it showed overall survival double for those individuals with free testosterone equal to or less than 0.7, and the grade is PG. I don't know what PG is.
And
it's not nanogram.
And what did it say
I think it's picograms.
Picograms? Say that
I think so.
It said 20 for total testosterone, but 0.7 for free testosterone, and my total like 30 days ago was 7, so I was quite a bit under the 20. But on the free testosterone, I was at 0.9, which is, I know it's not that much more than 0.7, but this particular trial, and it was a 2015 trial, it referred to testosterone levels, because again, what we're trying to do with Lupron is cut, testosterone medically. So, I mean, in my head, I can't help but thinking the lower the dang thing goes, the more efficient it would be, or more effective it would be. And that's kind of what this clinical trial had shown in 2015.
Right.
And I will send it to you.
Yeah, but I think what we're talking about here is not testosterone, but free testosterone. And I don't think any of us are really familiar enough with the concept of free testosterone to really comment whether 7 or 0.9 is a significant difference. Go ahead, Len.
Yeah, I just did a quick Google search on free testosterone. This is what I expected. Like many hormones, some are free in your blood or serum. Other hormones are bound to proteins. So usually albumin, it could be other protein. So free testosterone is the percentage of testosterone that is not bound to sex hormone globulin. It's just a protein in your blood. So only the free testosterone is, for instance, available or active and has anabolic effects, and presumably is capable of feeding your prostate cancer as well. So in other words, if testosterone is bound, it's inactive essentially.
So the free testosterone must be a function of the overall testosterone.
I would think so.
Mm-hmm. And that's the one that I think they're using on this particular clinical trial was free testosterone. So, but I don't know how one would, other than changing the type of, whether it be Lupron or some other type of drug, and that maybe that's why Korn was recommending. He didn't really get into the details of why he was recommending me to possibly start Zytiga now, early, to get my testosterone down lower. And I'm going to ask him because I don't really know.
Right. And some people do get a better response by switching the ADT drug. So you might want to talk to him about maybe switching from Recurrent to a different ADT drug.
Right. I just was wondering if anyone had any comments in regards to testosterone level, because it made me mental after I was reading this thing, and twice the overall survival rate was a pretty big number. Twice. I mean, I don't know. When you talk about OS, it's a kind of a random thing, but I will ask, and I'll let you guys know what he says.
Okay. And ask him whether it makes any, there's any value to switching to a different ADT drug.
I will do that as well, yeah. And maybe I'm just making something out of nothing, so it could be that I'm off on left field someplace. I don't really know, but okay. I just thought I'd ask. It's okay.
Okay. Well, keep us informed and send me that research. Though the one thing I did want to say is that the one important number other than testosterone is the dihydrotestosterone, which is the supercharged testosterone. And I remember that there was a situation with Steve Bornstein where his dihydrotestosterone was pretty high, even though his testosterone was low. But you have to get that measured separately, the dihydrotestosterone.
Oh. Okay.
Okay.
Yep. Thanks for the input.
Sure. Looked like Jeff Ledoux just jumped off. He just said something, and I don't know. Jeff, are you with us still? Okay. All right. No, Jeff. Let's see. Who else do we have on the list here? Well, we got through everybody. I had saved the last 10 minutes for Jeff Ledoux, and he's gone. So we have time. So is there anything? I see.
Rick, this is Jim Harrington. If anybody can
come to you. I'm so sorry.
That's okay. You just ignore me.
I'm so sorry. And I also see Robert's back on the call again. Well, Robert, we'll see if we can squeeze you in right at the end if you've got any questions.
Rick, it's okay. I can talk another time. It's okay.
Not at all. Let's talk about neuropathy. So Jim's been having a problem with neuropathy. Who else on the call that has done chemo has had issues with neuropathy, and what sort of results have they found in terms of treatment? Anyone?
Well, I've had neuropathy and still do, Rick. I don't have any per se results.
Right.
My chemo rounds ended like 6 months ago, and I was told I should wait 5 months and maybe it would go away on its own, and it has not. Okay. It's not as bad as it was, but it's still there.
Okay.
So I was told to take B12, which I'm taking. A B12 vitamin, it might help.
Yeah, I haven't tried B12. I will ask my med onc about that next week. It's not horrible. It's just the bottom of my feet. It's not in my hands. But again, like I mentioned earlier, I'm on chemo and I'm on docetaxel and I'm still on it, and I don't know when it's going to end. But so it sort of sits there. It's I haven't taken any drugs for it. I haven't done anything for it. It's a nuisance, but I can walk fine. It's not that. I also find that the type of shoes that you wear can be helpful to support the foot a little bit better. But I don't know. I just neuropathy can happen to anybody with or without chemo, I guess. But yeah, so yours didn't really get better after chemo. Of course, I'm still on chemo, so there's no hope, I guess, it's really going to get any better as I continue on docetaxel. As I say, I know it can be a terrible thing if it gets worse and worse, but so far it's an annoyance, and the bottom of my feet, both feet, kind of sore. It feels funny. That's one way to put it.
I'm
I've
very
never taken any drugs.
I'm very empathetic because I also get in the bottom of my feet, and I know how annoying and sometimes painful it
Yeah.
So I know what you're going through. I mean, there are a couple of drugs that work. Gabapentin is one. You can talk to your doc about gabapentin.
Okay.
And the other.
Have you tried that?
I did. I haven't tried it since I got the neuropathy on the bottom of my feet. I tried it when I had another issue, when I had cellulitis. I have not tried it. No, I mean usually with me I know it. I get it. It lasts about 4 weeks and it wears off, and then it comes back again. And it usually comes when the weather is cold, and I get it mostly in my heels and in my toes. And it's left over from the hormone therapy. In fact, the orthopedic surgeon asked me about whether I had neuropathy, which I thought was pretty perceptive on his part. The other thing that I would suggest is, like I said to you, talk to the Integrative Medical Center at Memorial Sloan Kettering.
Yeah, they're very good. I have a friend who uses them, and it's excellent. I haven't talked to them, but you're mentioning acupuncture. I never tried it.
Acupuncture may work. There are trials. I looked at the trials. There are trials going on with massage. There are trials going on with acupuncture. And just see if any of these complementary treatments might be helpful for you.
That's a good point, Rick. Thank you. No, that's a very good site, their integrative medicine site. It's I was looking at it when you sent that to me, and I'm close to that area. I can easily go into MSK.
Right.
And they're very good. Yeah, sure. Thank you.
Yeah, and you could probably
Jim?
Go ahead, Len.
Yeah, I just wanted to say there are 2 or 3 guys in my local prostate cancer support group who have had acupuncture for neuropathy, and they swear by it. They say it's been miraculous for them. Yeah, it may depend on the acupuncturist.
Absolutely.
And their skill level, I don't know, but they're very happy with the results.
Did they go to an acupuncturist that specialized in cancer, or just an acupuncturist, generally speaking?
General acupuncturist.
That's I've never had it. I'm a scientist. I'm somewhat skeptical of things like this, but maybe it's worth a try. That's good news. Thank you.
Yeah, I was very skeptical also, but these guys swear by it.
Okay.
The Integrative Center at Memorial Sloan Kettering, the guy that runs it, who's a medical oncologist, also has an acupuncture licensure. So my guess is that if you talk to them about acupuncture for neuropathy, they probably have a lot of knowledge.
I would think so. It's a good tip. Thank you so much, guys.
Pleasure.
Sure, good luck.
I'm just gonna move on. Jeff Ledoux, are you back on the call?
I am back on the call. I'll try and make this as short as possible.
Okay.
I got some extremely good news today. My PSA went down from 10.36 to 9.24, and I'm still on the Zytiga. They have dropped one of the prednisone because my blood sugar was going nuts. It is coming back down into line, so I wouldn't be surprised to see the other prednisone go as well and just stay with the Zytiga. I'm thrilled with this. I've also had my bone and CAT scan. We'll see about those on Wednesday. But I'm pleased with it. And I was going to quit Zytiga. This takes me out of play for a number of different clinical trials.
So the bottom line is that the PSA that came back today, you're down to 9.24?
9.24, down from 10.36.
Right.
And that was a surprise, and that may be exactly what we talked about last month, Zytiga flare.
Mm-hmm. Mm-hmm. But what was it that you said about the prednisone, Jeff?
He took me off, my oncologist took me off one of the 5 milligram prednisone, and that's bringing my blood sugar back down toward normal.
I see.
And my guess is that the other one is going to go away too.
Well,
it hasn't made any difference.
Well, I'm not too. I mean, the discussion of prednisone and Zytiga. I need some help here, because I do recall that there were some trials. I think the Stampede trials where they did not give prednisone with Zytiga, but most of the time they give the prednisone to compensate for the adrenals. Can anybody help me on taking Zytiga without any prednisone?
I don't believe it's a good idea. I have heard of some people who cut back, as Jeff has, and for the same reason Jeff has, and they're still okay. But if they try and eliminate it completely, then you run into problems. You'll have all kinds of side effects, GI issues, cramping, because you're going to be without any natural cortisol type hormone. That's why they give you prednisone, to replace the cortisol that's repressed by the Zytiga.
I won't find out about that until Wednesday anyway.
There is another drug, because I asked this question. There is another drug that they can give you in place of prednisone that will kind of do the same thing, not as well as prednisone, but it is an alternative. I remember asking Dr. Turner this question a couple of years ago, because I was leery of prednisone, and he said it's possible to go on this other substance, but I can't remember what it is.
Probably dexamethasone.
Yeah.
Yes, that's it.
Yeah.
That's it.
Yeah. This is Jim. I take the dexamethasone zone 2 before my chemo, and I've heard it's very similar.
Yeah, I mean, my understanding is that the dexamethasone is actually a stronger drug than the prednisone, Peter. It's an alternative.
Just lower the dose.
Yeah, you just lower the dose. I mean, they actually gave me dexamethasone last Wednesday, and I have a feeling that's why I probably felt good for a couple of days, because it was in my system. But they gave it to me to minimize inflammation.
In fact, Rick, there was a clinical trial recently, I think it was phase 2, so it wasn't a lot of guys, maybe 30 or so, where people who had seemingly become resistant to Zytiga were, instead of prednisone, they put them on Zytiga and dexamethasone, and then they started responding again to the Zytiga.
Oh, right. Interesting. Right, I vaguely remember that. Right, that's really interesting.
Yeah.
Some of you guys might want to, if you've been on Zytiga and you're not responding so well, let us know. We'll try and track that trial down so you can show it to your docs. Well, we're just about over the limit. I wanted to check in very quickly with Robert. Robert, are you still with us? I see your microphone's on, but we don't hear you. Are you there, Robert? No?
Can you hear me?
We can hear you now, yeah.
Okay. Yeah, I'm good. Thank you. This has been really helpful. You know, I am newly diagnosed and haven't begun treatment yet. So at this point, I don't have a lot of questions. My conversation with you the other day was really helpful, and I'm just waiting to see the med-onc on the 24th and figure out what my treatment plan is going to be, and I'm sure I'll have more questions then.
Okay. Who are you going to see, Robert?
I'm going to see Dr. Fong at UCSF.
Oh, that's right.
Yeah.
Okay. All right. Well, we're over the time limit. I'm glad I made it through. I wasn't sure I was going to, but I did. So thank you, everybody. I will try and get this posted, probably not till tomorrow. You need to listen to it again. But I will get it posted up on there, and then the next meeting that we have will be Tuesday, the 23rd. We've got a couple of breast cancer calls coming up. If you know anybody, please let them know. And I will start getting information out on the plenary for the 5th Monday, which will be about sleep and cancer. And that's about it. Anything else anybody wants to add before we sign off?
Have a good night.
Thank you, Jeff. Okay. All right. Good night to everybody.
Be well, Rick.
Good night now.
Thank you, Rick.
Thank you, Rick.
Take care.